Go ahead, Padma. Start your presentation.
Yes, sir. Thank you so much, sir. Namaste and good evening to all. Myself, Miss Padma. I'm in charge nurse in kidney transplant unit. And I take this opportunity to thank ISCCM team and my nursing head and my seniors and my colleagues. And today I'm taking a topic on RRT and nursing management of patients on dialysis. So I'll begin with the topic. Okay, this is basics of RRT and nursing management of patients on dialysis. And I'll talk about basics of renal replacement therapy. The definition: dialysis is the procedure used to correct the fluid and electrolyte imbalances and remove waste products from the renal failure patients. It's a generally worked through osmosis and filtration of fluid across a semi-permeable membrane with the use of a dialysate. And so here some of the essential functions of kidney I will discuss. And kidney plays two major functions. One is filtration of blood and regulation. In filtration of blood, it will remove all the metabolic waste from the body and especially those containing blood urea nitrogen. And it will regulate the blood volume and composition, electrolytes, blood pH and blood pressures. And important hormone produced by kidney is erythropoietin, whereas normal kidney produce this erythropoietin, but diseased kidney cannot. So that's why post dialysis, every patient used to get the erythropoietin injection to correct the hemoglobin. So indications for dialysis. The need for dialysis may be acute or chronic. So here acute dialysis is indicated as high rising level of serum potassium levels and fluid overload or impending pulmonary edema and increasing acidosis, severe pericarditis, also to remove certain medications or other toxins, poison or medication overdose from the blood. And chronic conditions is like a end-stage renal disease and diabetes, hypertension and IgA nephropathy. So these are the types of dialysis we do in the IP and OP area. Hemodialysis. Hemodialysis is a common procedure performed to treat acute or chronic kidney failure by removing waste and fluid from the blood, a task usually performed by the kidneys. So CRRT is a type of blood purification therapy used with the patients who are critically ill, hemodynamically unstable. And peritoneal dialysis is a home-based procedure which can be done in the home. And basic functions of dialysis mission is the three basic principles that make dialysis work are diffusion, osmosis, and ultrafiltration. This diffusion is defined as the movement of solute from an area of high concentrated to an area of lower concentration across a semi-permeable membrane. Osmosis is fluid moves from an area of high water concentration to lower water concentration across the membrane until to equilibrium. In ultrafiltration is the removal of fluid from patient and is the one of the functions of the kidney that dialysis treatment replaces. And these are the hemodialysis mission. This is a COB mission. The panels which we are panels and functions of the dialysis mission, and this is the connected tubings to the patient and it parts. This is the blood pump, this is bicarbonate concentrate, and this is acid concentrate. These are the blood tubings and dialyzer. This dialyzer also worked as a kidney in dialysis patients. And dialysis fluid tubings. These are the fluid tubings. And this mission has two systems, that is extracorporeal system and dialysis delivery system. In extra, back to slide. So this body called extracorporeal system and tubing system is nothing but this dialysis tubings. And I'll explain you this dialysis process in a simple way. So this is the axis of the dialysis line, So this blood, the access line will be cannulated. After the cannulation, this blood is arterial connection of arterial line given to the blood line and to access, and from the access blood will be flowing with the negative pressure and to the blood pump to dialyzer. So this is the dialyzer. So with the negative pressure it is flowing, and this in between dialyzer and this tubing, this blood pump, we have a heparin syringe here. This heparin will be this heparin goes through the these tubings, and just a minute. This syringe will be connected to the arterial blood line, and also there will be a arterial chamber, and pressure part will be connected to the monitor. So this blood will be coming to the dialyzer. In this dialyzer, there are some this we call as semi-permeable membrane. The blood will be flowing inside the membrane, and the dialytic fluid will be flowing outside the membrane. So this will be called as a this is outlet and this is inlet. The dialytic fluid will be going through this inlet and pumping out to the outlet. So from here, this is venous blood line. So purifying blood coming through the venous line to the clean blood will be flowing to the venous line. This is air detector trap. This air detector trap will be detecting air. Whenever there is air, we need to disconnect the tubings from the access line, and we have to clear the whole air, and after clearing the air, again we have to connect back to the access and restart the process of dialysis. So I want to tell you about the preparation of the dialysate fluid. Dialysate fluid where concentration. So this is 1:34 ratio. Acid and bicarbonate will be 1% and 34% of RO water. So here when we can see in dialysis machine, see this is bicarbonate concentrate and this is acid concentrate, and these lines will be from the RO water. So this will be mixed with RO water, and the concentration and delivery system will be done through the tubings, and here so extra blood urea nitrogen and waste products will be eliminated, and fresh blood will be flowing through the venous. So normal blood temperature for control modules will be, it is 36 to 37 centigrade. Some of the alarms in dialysis machine and troubleshooting. So, in HD machine, common alarms are blood alarms. So arterial pressure. If arterial pressure will be whenever there is line kinking, it will give alarm. So we need to check the lines time to time, and venous pressure. So venous pressure also we need to check, and immediately we need to act, or otherwise we need to call the dialysis technician and set it properly. And the transpermeable pressure and blood leak and air detector, as we discussed in the diagram. And dialysate alarm will be conductivity alarm and temperature alarm. If other alarms are like a water flow and heparin pump and power failure, etc. These are the some of the dialysis machine panels. So that this is air detector. Whenever there is air in the system, it will give alarm, and blood leak. Whenever there is a blood leak, it will give alarm, and arterial pressure, venous pressure, and temperature pressure. Also, this the already connected tubes are like this. This is blood pump, and bicarbonate concentrate and acid concentrate, blood tubings from the patient, and dialysis fluid tubing. This is, and this is the dialyzer. So nursing care of the patients in dialysis. So nursing management is dialysis is basically pre-dialysis care, during dialysis care, and post-dialysis care. So pre-dialysis care, the dialysis in the units basically goes on like this. So as soon as we receive the patient in a dialysis unit, explain procedure to the patient, and we need to check for the access, cannulating and connecting the HD machine. Before connecting the HD machine, we need to check the access and the hemodynamic monitor status continuously, monitor acid-base balance, and monitor electrolytes and blood parameters twice a week. For OP patients, we need to check blood parameters and electrolyte parameters every twice in a week. Ensure sterility of system before connecting to the patient or cannulating. That time we need to make sure that aseptic precautions are following or not. Maintain closed system and diet restriction. We need to educate the patient on diet, low protein intake and low sodium intake, low potassium intake, and target volume of fluid intake of the patients. And reinforce adjustment to prescribed medications that may be affected by the process of hemodialysis, which is hypertensive medications and diabetic medications. And pre-dialysis nursing assessment is weight checking, vital checking, potassium level checking, and priming of the dialysis machine. So when we receive the patient to the unit, we need to check the pre-dialysis weight, so that we know how much weight gain patient had, and according to that, doctor will advise ultrafiltration rate. And vital checking. Before dialysis, we need to check the patient vital status, so that we can adjust the hypertensive medicines. Or temperature for sepsis and respiration for fluid overload. And potassium level determines potassium level in the dialysis in the chronic setting. This is done monthly unless the patient is symptomatic. And priming of the dialysis machine. Whole drug that pass through the dialysis membrane, such as piperacillin, folic acid, and other waste soluble vitamins. Hold hypertensive medicine drugs, especially if systolic pressure is below 100 per physician order. And these also access to the patient circulation. Usually all OP patient, usually they come via AV fistula. Access to dialysis machine and dialyzer with a semi-permeable membrane, the appropriate solution. It is nothing but dialysis. And the time schedule will be in 3 segments, like a 12 hours in a week. We will divide into 3 visits, like thrice in a week. So handling of AV fistulas. Assess fistula graft for infection. So before starting the dialysis, we always need to assess the fistula, whether any thrombolysis or any infection, any discharge from the fistula, or any edema, swelling is there or not. So assess circulation in distal portion of the extremity. Auscultate for bruit, palpate for thrill, no IV or blood draws in that arm, and GRBS checking. Also, we should not check the blood pressure on the AV fistula arm, and follow aseptic technique while cannulating. This is the mission after priming done. And during dialysis, watch for hypotension because of blood volume connected to the dialysis machine, or fluid removal because of ultrafiltration. Patient may go into hypotension. Or watch for hypoglycemia, muscle cramp, nausea and vomiting. These muscle cramps are due to dehydration and nausea, vomiting. Some of the patient, if this dialysis process is new, they may get nausea and vomiting. Headache, itching, headache because of hypertension. Less commonly, disequilibrium syndrome and hypersensitivity reaction, arrhythmia, cardiac tamponade, seizures, or air embolism, etc. And post-dialysis monitoring is post-dialysis we need to monitor, and patients still persist hypertension or hypotension. According to that, we need to adjust their medication. Watch for bleeding from cannulation area. Check weight and compare. Watch for bleeding from cannulation area as well as in the body system, because during dialysis we are giving heparin injection. to the circuit. So we need to watch for the bleeding. Check weight and compare. Weight loss should be close to the fluid removal goal and set during the treatment. Document any unusual findings during the dialysis. And assess access site for bruit, trill, exudate, signs of infection or bleeding. After dialysis, once after we do the compression dressing to the AV fistula, then we need to monitor these things. Administering erythropoietin injection subcutaneously after the procedure. As I said before starting, this erythropoietin, this is the kidney will not produce this hormone. Only healthy kidney will produce this hormone. So after dialysis, we are giving this erythropoietin to stabilize this hemoglobin level. Give mixed medication if indicated. And education on diet, renal diet, low salt, low protein and low potassium diet, we need to educate the patient. And monitor blood and electrolyte panel twice a week. And this is the monitoring and follow-up record for OP dialysis patients. This is during their 4 hours dialysis time, we will monitor every half an hourly their vital signs and their other parameters like venous pressure, arterial pressure, native of how much we are setting and temperature, other remarks. So this is OP nurse dialysis monitoring form. This handbook is which patient carries every time, each visit when they come to the dialysis unit. And this is hemodialysis, pre-dialysis and post-dialysis, blood pressure, pulse rate, temperature, weight. Before how much they are weighing and weight gain how much from last dialysis to current dialysis. And this is post-dialysis and condition at the end, condition at closing time. And next hemodialysis schedule and time. And one more type of dialysis we do in ICU is CRRT. So care of patients in ICU during CRRT and SLED is low efficient dialysis. So here we, as soon as we receive patient from ER to ICU who needs immediate dialysis, so we need to identify the patient first, and we as soon as patient come, we need to check the vital parameter of the patient and to wait the patient daily to assess fluid removal, check for the access. If not, inform the doctor and arrange for the line insertion. And before that, we need to take the consent for line access and the CRRT procedure. And these are some of the catheters we use. And internal jugular and femoral will be using this curved catheter, curved dialysis catheter. And this is for subclavian. Subclavian is very rare moment we take the site of option. And catheterization and catheter care will be, first we need to counsel the family for decision making, CRRT procedure and catheterization. Informed consent will be taken before the procedure. And skin preparation, position to the patient and continuous hemodynamical monitoring and follow aseptic technique while inserting and handling of the catheters, and transparent dressing to be applied to monitor the bleeding, and regular monitoring of the patient, bedside x-ray to be done to check the catheter position, and watch for bleeding, tunnel infection, bloodstream infection, catheter dysfunction like thrombosis, malposition, kinking, central vein thrombosis. So these are the on-job pictures I am sharing with you. So how they are doing under aseptic precautions and how we are putting dressing to the dialysis catheter. This is a transparent dressing so that we can check the any discoloration, any swelling or any bleeding. So these are two type of catheter here, non-tunnel catheters. These are the short-term catheters which we are using for temporary purpose. This is called as a temporary catheters. We use it for internal jugular, it lasts for 1 to 3 weeks. Femoral catheters, basically we keep only 2 to 5 days. And tunnel cuffed catheters are, these are the perm cap, we call as a perm cap. These are the long-term catheters. It lasts for 1 month to 1 year. So these are the first generation and second generation tunnel catheters. It will look like these are the 2 different holes. Some well vascular like the separation will be like this. And this is triple lumen catheter. And initiating and managing CRRT in ICU, and monitoring during CRRT. So during CRRT, we monitor like this: 8 a.m. to 9 a.m. blood pressure, pulse rate, blood flow, dialysis flow, heparin, flushing hourly, pre-filter, replacement hourly, post-filter, net ultrafiltration hourly. So cumulative ultrafiltration and remarks. These are some of the details about the procedure and the vascular access and total number of dialysis, so on. So monitoring during dialysis is, we always remember to anticoagulation during CRRT can lead to bleeding, because monitor for signs and symptoms of bleeding in the oral mucosa, gastric aspirate, stool and injection sites. Check coagulation studies regularly based on the doctor's order. And take steps to prevent hypothermia, because during CRRT, the blood volume per minute will be 150 ml to 250 ml of blood volume remains outside the body in the CRRT circuit. So therefore, there is a chance to blood become cool and cause the patient's temperature to drop, and that is the reason we need to monitor the temperature regularly to prevent hypothermia. Check blood urea nitrogen creatinine levels at least daily to assess the CRRT efficacy. And routinely monitor the patient complete blood counts to check the unintended blood loss in case the CRRT circuit suddenly clots. Check electrolyte levels. Electrolytes are filtered out in the ultrafiltrate removed by CRRT. Hypophosphatemia is common in patients on CRRT and can be treated with supplements or by attending phosphate to CRRT fluids. And these are the complications, causes, signs and symptoms, and how to prevent during and after dialysis. So main complications of dialysis are angina, chest pain due to low oxygen levels in the heart. So the main causes are coronary artery disease, blocked heart arteries, anemia, storage of red blood cells, hypotension and anxiety. The main symptoms are pain or tightness in the chest. Patient may be pale or cold, sweating and have trouble in breathing. So immediately we have to, if we find the patient is having uneasiness and feel in breathing difficulty, so immediately we need to start the oxygen, and we need to closely monitor the blood pressure, watch for hypertension and calculate the fluid goal correctly. And hypotension. Removing hypertension may cause due to dehydration or taking BP pills before dialysis mission or because of heart disease. So these are the symptoms: low BP reading, dizziness, bradycardia, low pulse, loss of consciousness. And the management is get an accurate weight before a treatment. So based on that, calculate the fluid goal correctly, and ask patients if they have taken their pills or not before starting the dialysis. And cramps. Removing too much of ultrafiltration also causes cramps in the renal patients. Changes in blood chemistry, especially sodium and low potassium levels and hypotension. So the symptoms are painful muscle cramps, often in the hands and feet. So during dialysis, the most of the patients will complain the cramps, and some patients may have severe painful cramps. So before the dialysis process, then we need to do the accurate management, wait before treatment, correctly calculate the fluid goal, use the prescribed dialysate concentrate, and encourage patients to follow their salt and fluid limits. And heparin overdose, error in the heparin dosing or broken heparin pump. These are the main causes. And unusual bleeding around the needles longer than normal. These are the symptoms: unusual bleeding around the needles and longer than normal bleeding from needle sites and after the treatment. This is the management. Drop heparin doses correctly, use the right type of heparin, and monitor the heparin pump during the treatment. So hemolysis. Basically, this is one of the complications. During dialysis, blood will be flowing 150 ml to 250 ml per minute. At that time, there is a chance for blood to get the hemolysis. So bursting of red blood cells, main causes are kinked blood lines, inadequate water treatment that allows chloramines, copper, zinc or nitrates into the dialysate machine. Too warm dialysate or formaldehyde in a reused dialyzers. These are the causes. And main symptoms for these are nausea, headache, stomach and back pain, hypertension or hypotension, sometimes maybe cardiac arrest, bright red colored blood. And how to manage it is check dialysate conductivity and temperature before the treatment, monitor blood lines for things, and check the blood pump is calibrated for the blood line header being used. If you don't set the blood pump in a normal way, sometimes this blood pumping also may cause the hemolysis of the blood, pruritus, itching. The main causes are uremia, high blood urea nitrogen and high blood phosphorus levels, calcium phosphate, crystal under the skin, and the crystal under the skin, secondary hyperparathyroidism. And the signs and symptoms are severe itching on and off dialysis, red skin, crusting on the skin. And management is keep skin clean and dry always, and encourage the patient use moisturizer, and deliver dialysis treatment correctly. Ask patient if they are taking their phosphate binders or not. And power failure. Sometimes machine may have facing problem with unplugged machine or power outage. The symptoms are machine stops during treatment, no lights on machine, and continuous alarm will be giving. And to prevent that, check that the machine is completely plugged in before treatment. Be sure the machine has been maintained per center procedure. And hypertension. Another complication is hypertension. The main cause is fluid overload, patient missing their blood pressure pills, anxiety of dialysis disequilibrium syndrome, occurrence of neurological signs and symptoms. The symptoms are may have no symptoms except a headache and nervousness. Management is calculate the fluid goal correctly, ask patient if they have taken their BP pills or not, and encourage the patient to follow their fluid limits and treatment whatever the doctor advice. Seizures. The main causes of seizures in dialysis complications are severe hypo or hypertension, electrolyte imbalances, dialysis disequilibrium syndrome, seizure disorder or epilepsy. And the symptoms are change in level of misconsciousness, jerking movements of the arms and legs. The management is monitor BP regularly, check that patient with epilepsy are taking their epilepsy medication or not. Next complication is first use syndrome. The main causes of first use syndrome is reaction to ethyl neoxide used to sterilize new dialyzer, which is used in dialysis unit. Use of polyacrylonitrile membranes in the patients who take AC inhibitors, A class of blood pressure pills. The main symptoms are symptoms usually occur in the first 15 to 30 minutes of treatment: itching, chest and back pain, shortness of breath, hypertension, nausea, and general discomfort. Management is rinse the dialyzer well before treatment. Use the right dialyzer to prevent this symptom. And fever and chills. For in dialysis, the main cause of fever and chills is infection, sepsis, contaminated dialyzer or blood lines, which is connected to the patient, and endotoxin exposure to cold dialysate. So that is why we should maintain the dialysate solution temperature between 36 to 37. So main symptoms of this complication is fever during dialysis, feeling cold without a fever, cold because of cold dialysis, redness, swelling, tenderness, warmth or dryness from axis or other sides. Example, feet, skin wounds. And management for this, use aseptic technique to set up a equipment, use the aseptic technique to while inserting needle, and tell the nurse right away about major vital sign changes, and check dialysate temperature before the treatment. Use the right process to disinfect the dialysis machine and the water components, and test water and equipment for bacteria or pyrogens and endotoxins. Air embolism. Another complication is air embolism. Air bubbles and block a blood vessels. Causes is air detector is broken or not armed. A leak or loose connection in the extracorporeal circuit before the blood pump. Empty IV bags on the extracorporeal circuit before the blood pump will be the causes. And the signs and symptoms of air embolism is depends on the patient's body position when the air is infused. May include chest pain, double breathing, coughing, blue lips, fingers, toes, cyanosis, lack of oxygen, trouble seeing, and confusion. The management is arm the air detector throughout a treatment. Tighten all connections in the extracorporeal circuit. Check the normal saline level in the IV bag. Return the patient blood with saline with no air in the blood lines. Thank you. Over to Siddhartha sir.
Thank you, Ms. Padma, for the excellent talk on CRRT. To sum it up, as a, this renal replacement therapy is one of the important intervention we'll do in ICU settings, especially in acute kidney injury patients. Sepsis is the most important cause, and acute on CKD, rhabdomyolysis patients. Before initiating the dialysis, we have to know all the whatever components of the dialysis and everything, and the site of infusions, how to manage the lines. Okay, and coming when you are first time you are initiating the dialysis, you have to be vigilant for dyslipidemia syndrome. And that's why nephrologists and usually advise only short-term dialysis in first time dialysis patients. So for only 2 hours they will do, and they won't remove much fluid in the first setting. In ICU settings, normal dialysis machine used as a slide, slow, low efficient dialysis, especially in septic shock patients who are on inotropic support. Slide is one of the modalities used with a normal hemodialysis machine. And CRRT is the other way. You have preformed the dialysate fluid, fluid will be attached and it will be used as a dialysate. Okay. So now going to sum up brush up your knowledge, I will ask you questions. You can answer in the chat box. So coming to first question. This can be the side effects of hemodialysis.
Sir.
Can you see the screening?
Yes. 1 minute.
Are you able to see the screen? First question. This can be the same question, same problem with this PPT. Yeah. Can you? Is my screen is visible to everybody?
Not clear.
Oh, question B. Yeah, most of the things. Second question is, what is the correct definition of dialysis? What is the answer? The stomach is implanted or waste material is eliminated or a substitute of liver enzymes and increase the pumping of the heart. The question is correct B. So coming to third, how many times in a week you do the dialysis? Every day, once in a month, twice a day, thrice a week? For third question, for third question, answer is D, thrice a week. Coming to fourth question, which part of the dialysis machine will act as a kidney? It's a dialyzer or an nephrolyzer, kidneylyzer, hemolyzer? Yes, it is a dialyzer. It acts as a kidney, where the blood and the dialyzer fluid will separated by the semipermeable membrane, and excess water and electrolytes and acid balance imbalance will be corrected. Coming to question, what are the complications of dialysis? A, cramp, weakness, nausea, B, all the above. Yeah, answer is all the above. Coming to sixth question, most common cause of CKD. That is diabetes mellitus, hypertension, sepsis, are all the above. Most common. Here the question is most common. Yes, most common is the diabetes mellitus. Other causes are also important. Sepsis also there are causes, but most CKD patients have diabetes. Okay. That's the end of the presentation of today. So you have any doubt or any question, you can type it or you can ask. You can type it in the chat box. Still we have 15 minutes time. No questions? No doubt? So then good. Thank you for attending the class, everybody. So you want to get PPT? I doubt we have to ask the system. Will be recorded. I hope we can get the record session later on. So any other more request or question? So shall we round up? Yeah, thank you, ma'am. Thank you for excellent presentation, and we will call it a day.